Welcome to Mid-Run Pedia. My name is Benjamin, and today I'm going to talk about stomas. So in this video, I'm going to cover the classification of the stomas, the surgical principles, the physiological effects and fluid balance associated with stomas. I'll jump into the construction of stomas. We see how the loop, the double barrel, and the end stomas differ and the different attributes to them. And then I'll look at the complications of the stomas. So stomas are surgically postoperative communications between a hollow viscous and the skin to divert the normal flow of bodily contents, and this can be stool, this can be urine, and this can be air, and they can be temporary or they can be permanent. So there are many classifications that we can use to classify stomas, and one of the classifications is by function. In this we can look at things like the gastrostomy, we can look at the Urostomy, we can look at Ileostomy, we can look at the Colostomy and the Urostomy. We can also classify them according to the duration, where we can look at the temporary or the reversible and then the permanent or the long-term stomas. Then we can look at them by their construction, where we have the end, the loop, the double barrel, and some other people can talk about the spouted and the flash stomas, but we shall mainly focus on the end, the loop, and the double barrel because these are the most common. Then by site, we can have a Colostomy and Ileostomy, we can have a transverse colostomy, sigmoid colostomy, and so forth. Then by output, we can have the high output stomas and the low output stomas, and I'm going to explain just that as we go on in this video. So we can look at some of the principles of stoma creation. What do we always look at when you're creating a stoma? So one of the most important factors is going to be the site or where we are going to put this. And we can do pre-operative marking. We want to put it away from scars, away from skin folds, and away from bony messes. You want to put it within the rectus to reduce parastomal hernia risk. Then when we look at the technique, we're going to make sure we have adequate mobilization of the bowel loops without tension. We want to mature it, whereby we evert the mucosa to the skin. So always at our stoma, this mucosa of the bowel is going to be what is on top. Then we want to secure it with sutures to prevent retraction, and then we want to make sure that it has a good blood supply. That is, it should appear pink, and when it is pink, we consider that a viable stoma. Then for the closure, if it is a temporary stoma, it's going to occur after about 8 to 12 weeks, and we can do it locally where we anastomose that part, or we repair that part that we extruded, and then drop it back in, and we make sure that we close these layers very tightly to avoid herniation. So what are the indications of putting up stomas? So one of the indications is fecal diversion, and this is done mainly to protect anastomosis or to rest diseased or injured bowel. For example, if someone had a blood trauma to a sharp stabbing to the abdomen, and they had a perforated gut, you may maybe do some resection and anastomosis. But having done that, we want to give time for that to heal. So what we do is that we want to divert the fecal matter so that it does not pass there and interfere with that. So one, it can be to protect the anastomosis or rest the diseased bowel. It can also be to divert from perineal or pelvic wounds, because the perineum is also has a very complex microbial colonization, and sometimes even the passage of stool worsens that. So sometimes you can give that place a rest, the perineum, by giving a stoma, and that will help. So another time or another indication is to decompress whenever we have a distal obstruction, which can be maybe due to a tumor, or we can decompress the proximal bowel if resection is unsafe. Then it can be done as definitive, or it can be permanent. That is in a total colectomy. It is, for example, in someone with ulcerative colitis. If we have an inoperable malignancy, we can do that. If During trauma and emergency situations where we have colorectal injury, perforation, and ischemia of gangrene of bowel, you may do a stoma. It can be due to congenital pediatric conditions like Hirschsprung's disease and rectal malformations and neonatal obstruction. And it can be palliative in some cases. It can be for feeding access, for example, when you do a gastrostomy or jejunostomy. Because imagine someone with gastric outflow obstruction and we cannot relieve it. We may consider doing a jejunostomy to bypass the obstruction to the gastric outflow. And it can also be for the urinary diversion, the ileoconduit, whereby a segment of the ileum is connected to the ureter. It's isolated, and the urine will now flow through there. For example, if the bladder is removed due to bladder cancer and things like that, you can consider do the urinary diversion, which is called an ileoconduit. So what are the effects of stomas? When you do a stoma and do a ileostomy in particular, it's going to be a high output initially, and that is within the first few days or weeks. And over time, what's going to happen is that the body is going to adapt, and as it adapts, the villi are going to hypertrophy, and the absorption within that small ileum that is left is going to increase. But before that, we run a very high risk of a patient getting dehydration, hyponatremia, and metabolic acidosis because we are losing a lot of bicarbonate due to this very high transit, and the bicarbonate is meant to neutralize the stomach acids. So lack of this is going to cause a high risk of metabolic acidosis. Then in colostomies are kind of relatively friendly because their output is more formed. We have given time for digestion to take place, and most of the absorption that takes place in the ileum is done with that. So we have a less fluid loss. And when you do a urostomy, there's continuous drainage of urine, and also we have a risk of ascending infections because the ileum is kind of rich in microbiome, and then you have just given it a free passage to ascend up towards the kidneys and everything else. So when you look at the ileostomy and the colostomy, there are some few differences that may be asked on examination. We to know this. So location, you can tell the location. The other one is in the ileum, the other is the colon. When you look at the output, there is a high output, and it is liquid most of the time. And it's the ileum, it's liquid output. While for the colostomy, it's going to be formed and of lower volume. The fluid loss is going to be very high in the ileostomy, minimal in the colostomy. The skin care is going to be more intensive in the ileostomy because the ileum is going to have this time we're going to have a lot of corrosive things, the pancreatic juices and all those gastric acids being secreted. And this spill over to the skin, we're going to have a more intense than compared to the colostomy where we have already stool from everything, most of everything neutralized. Then appearance management is also easier with a colostomy. And look at the indications. Indications for ileostomy are most commonly IBD and total colectomy where the whole colon is removed. But the ones for colostomy, sometimes it's malignancy and obstruction. Yeah, basically just trying to avoid an obstruction that is there. We are like creating an alternative route, bypassing it kind of thing. Then reversal ileostomy is most of the time temporary, while the colostomy is most of the time permanent. And this is going to mostly come from the indications for doing it, as we have seen, the obstructions and cancers and stuff like that, colon cancers. So the construction, we can have the loop stoma. What happens in which stoma is that the loop of bowel is brought out through the abdominal wall, opened on the antenostoteric border, so the mesentery is non-dissected, it's left there, and then we create just an opening above. So we shall have two openings, the proximal and the distal, but they are supported by a bridge on the underside, done with the mesentery. And the indication of this is for temporary fecal diversion to protect the distal anastomosis, decompression of distal obstruction, and the ambulatory trauma of fistula cases. And the advantages of it is easy and quick to make. A reversal is simple and it maintains bowel continuity. And sometimes you may not even need to do a second laparotomy just to reverse this loop stoma. The disadvantage is that retraction or prolapse is a high risk, it is a high output because we're doing, if it is especially an ileostomy, it's going to be a high output. And that comes with those many complications, including malnutrition or malabsorption. Then the typical sites for the ileostoma are going to be the right or the left iliac fossa. Then when we look at the end stoma, what happens in the end stoma is that the end of the transected bowel is bowed through abdominal wall, and the distal end is removed, or it is left as a Hartmann pouch. So what happens is that the bowel is cut, and then the bowel is cut. One end, the proximal end, is going to be brought out onto the skin, but the distal end can be entirely removed. So we do a colectomy whereby the colon is removed and everything below that, or you do a Hartmann's pouch whereby you suture and close up the end of that distal part. So what can happen is that sometimes if you do the Hartmann's pouch, it can be reversed with time, but most of the times it is left forever. And the indications for this is that when you have no safe distal anastomosis, and that is we cannot do anastomosis yet to that distal part. If it is post-rectal or colonic resection, if you want to do a permanent diversion, for example, if someone has cancer and you want to bypass the place with cancer, probably there's an obstruction there. The advantage of it is that it's technically simple, it is secure and less prone to prolapse. The appliances are easy to take care of and put. The disadvantages are it has difficult reversal, the laparotomy, loss of bowel continuity, and the risk of Hartmann stump issues. For example, that stump sometimes may contain secret mucus, things like that, and that could cause a lot of progress. Typical site is in the left iliac fossa, that if it's a colostomy, and if it is a ileostomy, it's going to be in the right iliac fossa. Then we have the double barrel stoma, and this one, what happens is that the bowel is divided and the proximal end and distal end are brought out, and they're kind of put in close proximity like double barrels. So what happens is that the proximal is going to the proximal or the one above is going to bring stool, and the distal is going to secrete mucus. So the indications of this are if we want to preserve the distal segment for later reanastomosis, if there is trauma, obstruction, or inflammatory bowel disease, and the advantage is that both ends are easily accessible. So you can irrigate, you can clean, stuff like that. It's good for stage surgery, and we have less stump complications compared to Hartmann's pouch where you suture the distal end. The stump complications here can be managed more easily, and the disadvantages to that is that it's more complex to create. Appliances are difficult because we have two openings, skin irritation, and cosmetic concerns. And the typical sites for this can be for the transverse or the sigmoid colon, as well as the small bowel. So we have the complications, and the complications can be the early complications and the late complications. The early complications can be bleeding, and this one is usually minor. Pressure may solve this, or someone if they have coagulopathy, you can solve that. If you have blood thinners, it can be necrosis for his skin. It's very important. And most times when you're reviewing, you should always check, is my stoma still alive? Does it have a blood supply? Is it pink? And if it is not showing good life, you have to ensure it's not a full thickness necrosis, because a full thickness necrosis will mean you have to revise the stoma. You may require to redo the stoma. Then we have retraction, we have prolapse, you have infection or abscess, we have mucocutaneous separation, and then we have skin irritation, or what we call excoriation. Then we have the late complications, and the late complications are going to include a stenosis, whereby the stomach can become stenosed and therefore close, and we can dilate this or revise it if it's severe. You have parastomal hernia, we have chronic prolapse, you can have adhesions occurring and obstruction. We can have a high output stomas like when you do ileostomy, and this increase the fluid loss, electrolytes, and we can correct this by giving antidiarrheals like pyropyramide, codeine, or somatostatin, which is a growth hormone analog. Like octreotide. We can have another complication, which is malabsorption, And this malabsorption, we can correct it by giving oral supplements, diet modifications, parenteral nutrition. We can have mucus discharge, which can do by irrigation of the distal limb and good hygiene. You can have skin infections. And most importantly is the psychological impact on the patient who have had stomas. So we have come to the end of this video. And I think we have covered some of the important facts when it comes to stomas. And I would like to thank everybody who has supported me so far. And if you like this video or found some helpful information, I would appreciate if you left a comment, left a like, and share this video with another person. Thank you.